My dear colleagues, it is a pleasure to have you in this webinar of the International Menopause Society, which will be dedicated to the topic autoimmune disorders. This webinar has been supported by an unrestricted educational grant from Vecins Healthcare. Vecins Healthcare had no role in the selection of topics or speakers and has not vetted or reviewed the content of the speaker's presentation. For today, to address each topic in this webinar, we have two big professors. We have Professor Carlo Selmi, who will address the topic of estrogens and autoimmunity. Professor Selmi received his MD in 1998 and his PhD in internal medicine in 2002, both from the University of Milan. Between July 2005 and December 2014, he was assistant adjunct professor of medicine at the same division at University California, Davis. Since 2022, he is full professor of internal medicine at the Humanitas University in Milan. He currently leads the Department of Rheumatology and Clinical Immunology at Humanitas Research Hospital in Milan, and Professor Selmi has co-authored over 480 peer-reviewed publications with a Scopus Age Index of 80. His research track is dedicated to organ-specific and systemic autoimmune and chronic inflammatory diseases, including the clinical epidemiology and pathogenetic mechanisms of connective tissue disease, particularly systemic sclerosis, and psoriatic arthritis. Since 2023, he is the editor-in-chief of the Journal of Autoimmunity. Second speaker is Professor Francesca Motta. The title of her presentation will be Rheumatic Disorder Risk During Menopause. Adjunct teaching professor, Humanitas University, Pieve Emanuele, Milan, clinical assistant in rheumatology and immunology. She works in the IRCCS Humanitas Research Hospital at Rossano, Milan, postdoctoral research fellow at Humanitas University, Pieve Emanuele, Milan. Involved in teaching and training activities within the residency program in allergy and clinical immunology, as well as in the degree courses in medicine and surgery, and in medicine and biomedical engineering at Humanitas University, serving as adjunct teaching professor, supervisor of medical thesis and lecturer in both Italian and English, engaged in clinical and translational research on autoimmune diseases as a postdoctoral research fellow at the Autoimmunity and Metabolism Laboratory, Humanitas University. She carries out inpatient and outpatient clinical activities in the rheumatology and clinical immunology unit at the IRCC Humanitas Research Hospital. So now, before starting, just to show you some important information concerning the International Menopause Society. You see that you have plenty of resources at your hand, and also some other activities that I will show you at the end of the presentations. So firstly, we have Professor Carlo Selmi. Please, Professor Selmi, you may start your talk. Thank you.
Thank you, Professor Cano. It's a real pleasure for me to be here. I see there's more than 150 people connected, which is clearly states the very good health of your society. So congratulations to the organizers for putting together this pretty challenging area of discussion. Thank you for having us. Francesca Motta and I have been working together for several years now, so I'm particularly proud to be here with her today. And as you will see, she's the real expert on this matter. So my goal will be to discuss mostly about the role of estrogens in autoimmune diseases. I will try to keep this as practical as possible, because I know at the end of the day, we're clinicians. At the end of the day, we want to go for to see the patients and to have answers to solve their problems. So I will be focusing mostly on the pre-menopause part, so that Francesca, in a very complementary way, will be going for the subsequent part of the reproductive part of life. So these are the 4 items. I will touch largely on the 3 points at the beginning, while the HRT will be more related to Francesca's part, so we'll touch very briefly on it. So discussing immunology, and I mean basic immunology, is the best way to make an entire room fall asleep. That's the reality. That's the reality of science. So I will try to do the immunology in a very, very brief way. So females and males, men and women, are different from an immunological perspective. And if you want the take-home message from this part, it is clearly that women are much better at fighting infections compared to men. And that clearly has an evolutionary significance, because throughout evolution, until very few years ago, the #1 cause for death worldwide was infections. Before we followed the hygienic procedures, before vaccines became available. So up to then, clearly evolution had to protect the female sex to go to prevent our species from disappearing. So clearly today we know that the immune system of women works better against infection. And we know that in general, it tends to be more active in response to the same challenges. And we know also that the 2 main hormones, main sex hormones, on one hand, testosterone has a down-regulating effect on the cells that get more easily angry in the response. That is the innate immune system, namely NK cells and neutrophils. And we know that it also increases the production of the major anti-inflammatory cytokine, which is interleukin-10. On the other hand, in a very complementary way, estrogens increase the cell-mediated and the humoral immune response. Humoral means antibodies. And if you think of antibodies, we're already in the area of autoimmunity altogether. NK cell cytotoxicity, the production of pro-inflammatory cytokines, including interleukin-1, interleukin-6, and TNF-alpha. Not surprisingly, these are the 3 major cytokines involved, for example, in the queen of autoimmune diseases, which is rheumatoid arthritis. So if you don't think that women are better than men at fighting infection, we should just name COVID-19. We all know that when COVID-19 struck in 2020, more than 60% of casualties were in men. And that clearly shows that the more severe forms of COVID-19 pneumonia, the more severe forms of cytokine storms in these patients were clearly in men. So it's been known for some time. We do know that from animal models. For example, if you take mice that are deleted for the estrogen receptor alpha, you do see that white blood cells are reduced, as well as dendritic cells. Dendritic cells are the cells capable to present the antigens to begin with. And we know thus that the presence, the activity of estrogens is capable to maximize the impact of antigen presentation by the cells. But if you want to go a broader look, if you want to take a broader look at the immunological effects, you can go to this table, which has not changed that much in the past 9 years. And let's start from the bottom. We do know that estradiol, compared to other sex hormones, clearly has an increased antibody response. Women of childbearing age have a better response, for example, better serological response, for example, to vaccines compared to men or to postmenopausal women. Same thing for B cells. Same thing as we responded on the cytotoxic type of T cells. Same thing as we have said on the cells that are the first line of innate defense against infection, that is neutrophils, and NK cells. However, for completeness, we should also mention that the differences in the immune system that we observe between men and women are not just related to hormones, but are also related to probably to genetic differences, particularly related to the sex chromosome, to X chromosome, which carries some of the most important immune genes in our response, including FOXP3. FOXP3 is the signature of T regulatory cells, of classical T regulatory cells, and it maps on the X chromosome, and is also capable to invariably escape the X chromosome inactivation. So in a nutshell, we have women who express double dosage of FOXP3, women who express one dose of FOXP3, and a large number of shades of gray in between. How does that translate to practice? Well, easier said than done. Autoimmune diseases are strikingly dominant in women. Not surprising. Systemic lupus erythematosus is like 9.5 to 1. Sjögren disease, Zika, autoimmune Zika syndrome is like 8 to 1. You can go all the way to autoimmune thyroiditis is also 9 to 1. If you look at rheumatoid arthritis, is a little less striking, but it's still 6 to 4, 3 to 2, or somewhere in that ballpark. We have some conditions that start to drift towards the male gender. And you see, for example, type 1 diabetes or axial spondyloarthritis. On the other hand, some non-clearly autoimmune diseases such as Crohn's also seem to be more prevalent in men compared to women. And if we look at rheumatoid arthritis affects, as we said, women in approximately between 60 and 80% of cases. We do see that before menopause, early menarche at age seems to increase the risk of developing disease along with a family history of rheumatoid arthritis, tobacco smoking. Oral contraception does not seem to change the risk of developing rheumatoid arthritis. Pregnancy, we'll come back to that in a second when we talk about more focusedly on pregnancy, does reduce the activity of rheumatoid arthritis. This is very relevant. Conditions immunologically driven like rheumatoid arthritis tend to do extremely well during pregnancy. Breastfeeding, on the other hand, so after delivery, you may have a flare of the disease. But at that point, quite frankly, things get easier because our hands are not as tight as they are, of course, during pregnancy. And in case of after menopause, I'll leave that to Francesca in a little bit. We did mention the X chromosome inactivation as one of the possible mechanisms, and I do like to talk about the other side of the autoimmune disease, completely different from immunological perspective, which is systemic lupus erythematosus. Systemic lupus erythematosus does have a clear female predominance, but has a complete opposite fingerprint from the immunological perspective. And that is the reason why systemic lupus, unless it's in remission at the beginning of pregnancy, can and might as well flare during pregnancy. And this is something that needs to be kept clearly in mind. On the other hand, there seems to be an impaired balance of the X chromosome inactivation, probably once again telling us that the gene silencing is trying somehow to silence the disadvantaged X chromosome in the cell. We do know that estrogens do change compared to the activity of systemic lupus erythematosus, since it clearly correlates with the SLEDAI, systemic lupus erythematosus disease activity index, and we do said that quite clearly. And the reason for that is what we said at the very beginning, particularly the activity on B cells, including B cell stimulating factors such as BAFF, which, by the way, is one target of the biologics we use today in systemic lupus erythematosus. But to give an assist to Francesca Motta in a second, we do know also that the immune system does tend to get older with us. It's called immunosenescence. It's generally well reflected by the reduced response to vaccination at older age, which, by the way, is also the age in which vaccines are most needed. Nevertheless, when lupus appears after the age of 50, which we may disagree, it's an elderly onset systemic lupus erythematosus, we do see there's a lower female to male sex ratio, there's different phenotypes, there's more frequent Zika syndromes, there's very different survivals. Of course, these need to be corrected also by the age at disease onset. So what about pregnancy? I know you're looking at the other side, but please allow me to take a chance here to give some clear message about what we know about pregnancy. I tried to summarize it in this cell from a very recent paper, and the conditions I want to focus you mostly is systemic lupus erythematosus, well, systemic sclerosis, Sjögren's syndrome, and rheumatoid arthritis. In the fact that it's particular systemic lupus erythematosus to be increasing the risk of virtually all negative pregnancy outcomes, with the exception of gestational diabetes, despite the use of glucocorticoids. On the other hand, you see a significantly milder risk associated with rheumatoid arthritis. So the chances of a good pregnancy in women with rheumatoid arthritis, if pregnancy starts with the disease in remission, is only slightly elevated compared to the general population. And the other major issue, of course, is medications. So we want to be absolutely clear on this. The European League Against Rheumatism, the European Society of Rheumatology, just came out with this very clear paper showing that some drugs are compatible with pregnancy and should be continued. Number one being hydroxychloroquine, Plaquenil. I don't want to use commercial names, but Plaquenil is definitely very well known, as well as biologics, at least in the first trimester, in which we know that the risk for the fetus is extremely low. And if you remember, since rheumatoid arthritis will do better during pregnancy, the need for using this medication is also reduced. The drugs, on the other hand, that you do not want to use, that you want to wash out way before, include methotrexate, and methotrexate is the #1 drug we use for virtually any rheumatological condition, needs to be stopped at least 3 months before conception, which implies the need for a significant counseling for pregnancy in our women. In this country, in Italy, 1 in 2 pregnancies is not planned. And this is clearly a potential burden on the success of the pregnancy, on the timely use of medication. The other 2 big no's, the other 2 drugs to be absolutely avoided, even prior to conception, are cyclophosphamide, mycophenolate, and also leflunomide. All drugs which are used for different indications, cyclophosphamide and mycophenolate mostly for connective tissue disease, methotrexate, and leflunomide for rheumatoid or other forms of arthritis. Drugs and lactation, not much changes here, plus the fact that potentially virtually all biologics can be given. The transmission through breast milk is very minor. These are huge molecules that will be digested even in the mouth of the newborn. So this generally leads to a pretty easy use during lactation. And then some very practical message. So if it's rheumatoid arthritis we're dealing with, try to plan the pregnancy when the disease is in remission and no dangerous drugs are being used. This is the only message we need. Be careful. Align with the rheumatologist to be absolutely sure that your patient will arrive with disease in remission. In this case, the risk of flaring during pregnancy is virtually non-existent. It will be some magical, immunologically magical 9 months for the patient. Antiphospholipid syndrome, we know that. The highest risk is when triple antiphospholipids are positive. All triple, meaning anti-cardiolepin, anti-beta-2-glycoprotein, and LAC, lupus anticoagulant. And please remember that these positivities need to be checked twice, need to be positive at least twice, at least 12 weeks apart to be defined positive, because the risk, especially with LAC, of finding false positives is very, very high. And in this case, again, consider previous history, low-dose prednisone, consider hydroxychloroquine, consider low-dose aspirin, and possibly low molecular weight heparin. We do know much less about Sjogren's syndrome and systemic sclerosis. Systemic sclerosis, in the case of systemic sclerosis, it really depends on the type of visceral involvement you want to be careful about, especially pulmonary arterial hypertension, the kidney involvement, or the interstitial lung disease, or the diffuse cutaneous disease. In this case, generally patients are very hard to get off prohibited drugs such as mycophenolate or cyclophosphamide. And we have even less data for Sjogren's syndrome, in which, of course, we have to be extremely careful for the positivity of anti-Rho for the risk of fetal congenital heart block. And then I'm going to just give an assist to Francesca on this. We have a lot of data now on hormonal replacement therapy, but my personal view is that the choice is yours. The choice needs to be taken by the gynecologist. There's very few patients in which we will be against that. Very, very few patients. In general, doing hormonal replacement therapy is a great solution for many of our patients, especially those that are in chronic pain, since the hormonal replacement therapy will ameliorate the symptom in our patients. But again, Francesca Motta will tell you way more about this. I'm done. The immune system is strongly affected by estrogen, and that also will change the immune profile after pregnancy. It's mediated directly. It's mediated also by the microbiome. We haven't talked about that. By the microbiome and the estrogens, in terms of the immune modulation, it's a two-way street, with estrogens modulating the microbiome and the microbiome being able to modulate the sex hormones. On the other hand, we do know that estrogens may contribute to autoimmune disease activity. I wouldn't say susceptibility, but it would definitely do activity. Pregnancy needs good timing, good counseling, and excellent patient information to avoid unplanned pregnancies and to avoid the use of unplanned medication. Hormonal replacement therapy needs us to work together in each specific case. With this, I thank you very much, and I thank the people I have the privilege to work with in Milan, and I'd be happy to take any question that you may have for me. Thank you very much for your attention.
Many thanks, Professor Selmi. Has been a very interesting talk. You know that we are almost absolutely ignorant about immunology, and it's an area that sometimes we find in our professional practice. So every message is well received, and so we are happy. So now we have the second speaker is, as I was commenting, Professor Francesca Motta, who will speak about rheumatic disorder risk during menopause. This is something which is very, very directly related with what we are supposed to do as members of the IMS. So, Professor Motta, the floor is yours. Thank you.
Yes, thank you for the presentation and the introduction. I will address the topic of rheumatic disorder risk during menopause. And we know that rheumatic disorders are inflammatory disorders affecting joints, bones, or connective tissues, and their pathogenesis is due to the combination of genetic susceptibility and environmental factors, with a relevant role of sex hormone in the pathogenesis. And we can divide inflammatory rheumatic diseases into three main categories, which are inflammatory arthritis, connective tissue diseases, and vasculitis. And most of these diseases have a strong female predominance, which is at least partly due to sex hormones, as Professor Selmi correctly talked about before. And this is supported also by the fact that the main differences in immune cell numbers and activities and function manifest during post-puberty and adulthood. In fact, there are the main differences between male and female immune system during adulthood. And there are several studies showing also that these have an impact in women, in particular during pregnancy. What we know less is what happens in older age, in particular after fertile age in women. And so I anticipate you that I will ask more answer than I will give, I will ask more questions than I will give answer, unfortunately, in this presentation. We know that pregnancy has a strong impact in female patients with rheumatic diseases. And as Professor Selmi mentioned, we know in particular that the two main rheumatic diseases behave oppositely during pregnancy. In fact, systemic lupus erythematosus tends to worsen and have a higher risk of flare during pregnancy, while rheumatoid arthritis improves and flares are less common during pregnancy due to the changes in immune system due to rise in estrogens. We know regarding fertile age, what we don't know is what happens after menopause. In fact, there are only a few studies showing the impact of menopause on autoimmune and rheumatic diseases. But at least from a theoretical point of view, there are some pathogenic pathways that support the potential role of menopause on autoimmunity. In fact, with the reduction of estrogen, there is a polarization of cytotoxic T cells with increased production of interferon gamma, TNF alpha, a reduction of the number and the activity of T regulatory cells, which can lead to increased autoimmunity. And also after menopause, there can be an accelerated inflammaging, which is supported by the stimulation of the immune system due to pathogen and damage associated molecular patterns, which can stimulate the innate immune cells and the adaptive immune cells to produce pro-inflammatory cytokines, which can support the development of autoimmunity and inflammatory diseases. So there are a few studies describing the immune changes after menopause in women with average menopause. And in particular, these studies show that there is a polarization of monocytes toward and M1 pro-inflammatory phenotype with increased production of pro-inflammatory cytokines such as IL-6, IL-17, and TNF alpha, which are the main cytokine, for example, of produced in rheumatoid arthritis and which we target with biologics. We know that after menopause there is a modulation of B cells. There is also an increased cytotoxic activity of T lymphocytes with a reduced function of T T regulatory cells, and also an increased cytotoxic activity of NK cells. It has to be highlighted also that the immune changes occurring in average menopause are different compared with the immune changes occurring in premature ovarian insufficiency. So it is always important to ask female patients their age at menopause, also because the underlying immune changes can be different. So what happens to rheumatic diseases in menopause? So let's start from the risk of onset of rheumatic diseases. The most studied rheumatic disease on this aspect is rheumatoid arthritis, which has a female predominance, with most diagnoses performed around the age of menopause, with a female predominance, which reverses after the age of 75. And we know that early menopause may be a risk factor for the onset of rheumatoid arthritis, while later menopause is protective for rheumatoid arthritis onset. And this can be expected considering the pathogenesis, because in rheumatoid arthritis, we know that there are some genetic predisposition as a risk factor. So in genetically predisposed female patients, such as those carrying the shared epitope or with specific isoenzyme, for example, of PAD4, these patients can be genetically predisposed to the onset of rheumatoid arthritis, and after menopause, there can be a predisposing environment because immune cells are modulated and are more pro-inflammatory due to the estrogen drop. And so T helper cells can be more polarized toward a pro-inflammatory phenotype, with presentation of autoantigen and formation of citrulinated peptide, which can drive immunization. And also the reduced levels of T regulatory cells can also increase the risk of autoimmune amplification. And also, after formation of autoantibodies, the low sialylation of the Fc fragment of this autoantibody can further increase inflammation in these patients and further worsen and enhance inflammation. At the tissue level, also after menopause, there is the production of local estrogen metabolites, which can increase the formation of inflammation, the formation of pannus, and lead to bone destruction. Regarding psoriatic arthritis, which is the other big inflammatory arthritis, we know that the percentage of incidence is similar between male and female, but it seems that psoriatic arthritis behave similarly to rheumatoid arthritis, as longer reproductive period is associated with a reduced risk of late onset psoriatic arthritis and also of skin psoriasis. And there is a reduced risk of developing psoriatic disease, including both skin psoriasis and psoriatic arthritis, if age at menopause is greater than 55 years of age. Actually, there is only one study, which is a big study, studied on psoriatic arthritis risk after menopause, and it has been proved that for both psoriasis and psoriatic arthritis, the age of natural menopause and reproductive years are the main protective factors for onset of psoriatic arthritis. So for late menopause and longer reproductive period, there was a strongly reduced risk of onset of psoriatic arthritis. And from mathematical analysis, it can be concluded that at least 20% of psoriatic arthritis could be prevented if all women had a menopause at a late menopause, so menopause after the age of 55. What happens to the risk of connective tissue diseases? So let's start with the lupus erythematosus, which has a strong female predominance. And we know that women in the postmenopausal period have a significantly lower risk for the onset of lupus compared to fertile women. With the risk in fertile age, with the ratio female to male in fertile age being up to 15:1, while in postmenopausal period being reduced to 5:1. And risk factor for lupus onset after menopause are early age at menarche, use of oral contraceptive, early age at menopause, surgical, so anticipated menopause, and use of hormone replacement therapy. And also women who develop lupus after menopause have a more favorable prognosis and natural history with less severe disease, in particular regarding skin manifestation, renal involvement, constitutional symptoms, leukopenia, and autoantibody. What about Sjogren's syndrome? Sjogren's syndrome has a peak incidence in menopausal age and a strong female predominance. And this is because estrogens seem to protect the exocrine glands, acinar cells from atrophy and apoptosis. So after menopause with loss of estrogens, these acinar cells are no more protected, and they can undergo apoptosis with release of autoantigen, which in with a pro-inflammatory polarization of immune cells can induce the maturation of an immune response, autoimmune immune response, which can lead to further apoptosis with the maintainment of this vicious circle. And so this can be the pathogenesis of Sjogren's syndrome, particularly accelerated in menopause. It has also been shown in murine models that loss of estrogen led to the infiltration of lymphocytes in exocrine glands with apoptosis and also production of autoantibodies specific for Sjogren's syndrome. So this is the summary of what we already said. So we know something about some rheumatic diseases, but we know nothing regarding most of the others. And what we know, it's only partial and not conclusive. So what about the course of an already established rheumatic disease after menopause? Starting from rheumatoid arthritis, we know there are several studies showing that menopause induces a higher disease activity in female patients, worse patient-reported outcome, more fatigue, sleep disturbance, joint damage, and quality of life. And hormone replacement therapy has provided conflicting results. So there are some studies showing a potential beneficial effect of hormone replacement therapy in rheumatoid arthritis patients after menopause, while other studies did not confirm this data. Regarding psoriatic arthritis and spondyloarthritis, we don't have data. Regarding spondyloarthritis, we know that there are two little studies showing that an inverse correlation between erythrosedimentation rate and estrogen levels, with a slight improvement in peripheral arthritis and clinical activity after use of estrogen replacement therapy, while another study did not confirm a protective effect of estrogens on radiographic progression. So no conclusive data. Regarding connective tissue diseases, there are studies on systemic lupus erythematosus showing that women with lupus have generally menopause at average age, which can be anticipated in patients treated with immunosuppressive treatment, in particular cytotoxic treatments for lupus, for example, cyclophosphamide. And we know that after menopause, usually systemic lupus erythematosus improves with a decrease of the disease activity index, a reduced frequency of flares, and a reduced magnitude of flares after menopause. But after menopause, there is an increased accumulation of damage after each flare, and also there is a risk of accelerated atherosclerosis and arterial vascular events in postmenopausal women with lupus. Even though after adjusting for confounders, it looked like it was age associated with damage accrual rather than menopause itself. In women with lupus, also particular attention should be paid to hormone replacement therapy because it has been linked to an increased risk of flares, and also in lupus, but also in rheumatic diseases, in particular in connective tissue diseases. Antiphospholipid antibodies should be tested before using hormone replacement therapy to evaluate the risk of thrombosis and should be avoided in patients with positive antiphospholipid antibodies. Regarding Sjogren's syndrome, it is difficult to say because Sjogren's syndrome is characterized by symptoms which largely overlap with menopausal symptoms, so Sika syndrome, vaginal dryness, fatigue, which can be mistaken and confused with menopausal syndrome, and the specific impact of menopause on the course of Sjogren's syndrome has not been studied. But there is a small case control study which describes a risk of the use of hormone replacement therapy for the development of Sjogren's syndrome. Systemic sclerosis is a rare connective tissue disease involving the skin, with thickness of the skin, vascular involvement with ulcers, and potentially an involvement also of internal organ with interstitial lung disease and pulmonary hypertension. And we actually don't know what happens to women undergoing menopause to patients with systemic sclerosis undergoing menopause. There are two studies which are old studies from the 90s. One showing the potential beneficial effect of menopause on skin fibrosis, showing that the skin fibrosis is reduced in menopausal women compared to the fertile counterparts. And the other one showing that in a specific subset of this rare disease, in particular in women with anticentromere antibodies, these women can have an increased risk of developing pulmonary hypertension after menopause, with hormone replacement therapy, which can be beneficial in preventing this complication in this subgroup of patients. And regarding in general hormone replacement therapy in systemic sclerosis, there is a lack of data, so we cannot conclude in a specific direction. So we know something about the disease, the course of rheumatic diseases in menopause, and we should also mention the complication of rheumatic diseases which can be worsened by menopause. And the queen, unfortunately, of complication is osteoporosis, which complicates menopause and can be further complicated in patients affected by rheumatic diseases, in particular in those with early menopause and in patients who took or are taking glucocorticoids for the rheumatic diseases. Also, patients with elevated disease activity have an increased risk of osteoporosis in menopause, patients with rheumatoid arthritis and positivity for anti-citrullinated peptide autoantibodies, and patients with reduced physical activity. Other complications can be the risk of accelerated atherosclerosis, in particular in patients with rheumatoid arthritis and lupus, and the risk of osteoarthritis, although the effect of menopause in patients with rheumatic diseases regarding the development or worsening of osteoarthritis is difficult to define because there are contradictory results. So in conclusion, we know we only have a partial vision of the impact of menopause on systemic sclerosis, so deeper insights are needed, but we can say that both the onset and the course of rheumatic diseases can be influenced by menopause, and it is important to study and to increase the knowledge of menopause rheumatic diseases to develop personalized treatment approaches which can improve the management of female patients with rheumatic diseases. And also we mainly study the impact of menopause on rheumatic diseases, but also we should study the impact of rheumatic disease on menopause. In fact, how is, for example, quality of life, pain, menopausal symptoms in women with rheumatic diseases compared with women without rheumatic diseases. So I thank you for your attention.
Many thanks, Professor Motta. We had two excellent presentations. I think that probably what a good conclusion is that we have in front a huge discipline with many implications, of course, in menopause and gynecology, but in many other disciplines, and that is still plenty to know and all very, very relevant. Well, we have many questions here. Before starting questions, please write your name and your country. And we will ask you just with your name and mentioning your country as well. As I was commenting, we have here many questions. I will start with a question of, because we have Professor Naftolin with us, so it's a real pleasure. Professor Naftolin, hello, and a privilege to have him. He has raised a couple of questions. One of them is, since one of the action of androgens and progestins is inhibiting estrogen receptor expression, what can be expected when administering tamoxifen to women or men? Professor Selmi, please, you start.
All right. So number one, that's an excellent question. Well, we know that tamoxifen is capable to create a significant pain syndrome. Okay. On the other hand, we do know that it may trigger flares of systemic lupus erythematosus, particularly actually skin lupus. Okay. On the other hand, other conditions are potentially unaffected.
Okay. Shall we address the second question? Professor Naftolin, Francesca, please. Is there a relationship between rheumatoid arthritis and osteoarthritis?
Yes, there is a relationship because rheumatoid arthritis can be a risk factor for secondary osteoarthritis. In fact, the destruction of joints, in particular in rheumatoid arthritis, untreated or difficult to treat, can induce alteration in the joint, which can predispose to the development of osteoarthritis in the future. And also menopause can accelerate this process. Because, for example, in menopause, there is an increase in inflammation. So beyond the inflammation due to rheumatoid arthritis, there can be also the inflammatory alteration due to aging and to the loss of estrogen. We can further accelerate inflammation and osteoarthritis.
Okay, thank you. Another one is for you, Professor Selmi, is as a general screening method or for following immune tone, what is the best test? ESR, interleukin 7-10, CRP, other? Should this be tested in evaluating postmenopausal women for MHT?
Can you repeat the beginning of the question? What is the best marker for?
Which is as a general screening method, which is the best test, ESR, interleukin 7-10, C-reactive protein, CRP, other. Should this be tested in evaluating postmenopausal women for MHT?
Okay. Now I can read it. There's no need to monitor anything, frankly. I mean, there's no way to measure the function of the immune system except for the frequency of infections and potentially autoimmunity. So the evaluation is strictly clinical. ESR and CRP are excellent inflammatory markers, but for example, in most cases of rheumatoid arthritis are only positive in about 60–70% of cases. In others will be normal. Even more for lupus, for SLE, for systemic lupus erythematosus, CRP will be elevated mostly for infections, not for the activity of the disease. So quite frankly, unless you have a suspicion that the patient may be immunodepressed or have a chronic inflammatory disease, there is no need to screen for anything. I hope I was clear and I got the question right.
Thank you. Now for you, Francesca, cardiovascular disease is an inflammatory process. Is this a form of autoimmune disease? Does this predict improves cardiovascular disease risk in menopausal women, and should it be taken into account in evaluating the value of MHT?
Well, cardiovascular disease is an inflammatory, as an underlying inflammatory substrate, and this can be accelerated in menopause. This is particularly true for some category of patients. I would say for patients with rheumatic diseases, this is particularly true for patients with rheumatoid arthritis and lupus. And I would also add patients with psoriatic arthritis, which can have a metabolic syndrome underlying. And this should be addressed and managed not only from an inflammatory point of view, so controlling the disease activity, the rheumatic disease activity, but also the usual risk factor for cardiovascular disease.
Okay, thank you. There is now a question. Well, the question was raised before I informed that this is anonymous. Is there any evidence that some virus, such as COVID, can deplete estrogens in women, Professor Selmi?
I don't think there is. I don't think there is. There's been immunologically, basically any immune-mediated condition has been ascribed to COVID-19 in the recent past. There's case reports of pretty much anything starting after COVID-19. I am not familiar of estrogen deficiency in this case, but I may be wrong. Frankly, it's a little outside of my expertise. Apologies.
Thank you. Now is a question of Dr. Chris Criatura. Is pregnancy itself a risk factor for autoimmune disease? Is there a higher risk of autoimmune disease in women who have carried pregnancies made of gametes that are completely unrelated, the so-called surrogacy or donor egg pregnancies? Francesca, please.
Well, regarding the second part, I would say we have no data. And I would say that pregnancy itself, it's not a risk factor for autoimmunity. While when we have a patient with an already established rheumatic disease, it depends on the rheumatic disease, as some of them can worsen while some others can improve, as Professor Selmi explained.
Okay.
If I may comment real quick on this, I do agree. The pregnancy history of women does not impact the risk for most autoimmune disease. The word data, I know it may sound funny, but the word data on nuns, religiously consecrated women with primary biliary cholangitis, autoimmune cholangitis, but those were then disproven. So quite frankly, the answer would be no. I don't think there's anything about the unrelated type of pregnancy. However, this opens the old story, which has never really led to a complete clarity of microchimerism. So the remaining of fetal genes in the woman, circulating either free DNA or, well, clearly they're usually male cells to be described. But these have been indicated for many autoimmune diseases for like 30 years, never reaching definitive proof. So the answer is probably not.
Okay, now another question here is, why biologics cannot be used in second trimester and third trimester? This is generally reverse for most drugs, which are unsafe to be used in first trimesters. Thank you.
It's a matter of transplantation, meaning that because they cross the placenta after the first trimester, because it's an active process, the transfer of the antibody. It gets captured by the FC segment of the antibody and brought through the placenta in the second and third trimester. In the first one, it doesn't happen. That is also the reason why the only biologic we have, which does not have the FC segment, can be used throughout pregnancy for the whole 9 months. It's the only one approved for use throughout pregnancy. It's called sertolizumab.
Now, this is a question for both of you from Dr. Lara London. Professor Selmi suggested that decreased estrogen should decrease AI activity, whereas Professor Motta suggested that AI activity increases when estrogen drops in menopause. How can this be reconciled?
Well, I'll start and then I'll leave it to Francesca. It's different conditions we're talking about. It's different immunological mechanisms. It used to be called Th1 and Th2. Now that it's much more complicated than that. But that is why it happens. Francesca, please.
Yes, actually, before infertile age, there is a polarization towards immunity protecting the potential pregnancy. So some type of immune mechanism are enhanced while others are suppressed, let's say. So some diseases are usually more common in fertile age, such as lupus, while others can as an increased risk or a worsening after menopause. It depends on the immune processes. I would also add that after menopause, menopause seems to be also the turning point between immunity and inflammation, because there is an slowly increasing inflammation with aging, and in women there can be just a cutoff after menopause with an increase of let's say innate immunity and inflammation, which rises and continue to rise starting from menopause. And this type of inflammation favors can favor autoimmune disease, but in particular it can favor accelerated atherosclerosis and inflammaging.
Okay, there is the next question is also for you, Francesca. Professor Motta, can HRT improve outcomes for those women with psoriatic arthritis?
We know we have a few data, so we have to study. For psoriatic arthritis, there are some conflicting data. One study showed that it can improve, while the other did not confirm this result. So actually, we don't know. We do know that hormone replacement therapy can have a trophic effect on the chondrocytes, so on the joint in general. But regarding the specific immunity associated with psoriatic arthritis, so the disease activity of psoriatic arthritis, we don't have enough data to conclude.
Okay, now from Dr. Taboni, referring to all advantage and disadvantage of estrogen, do you suggest it for late menopause patients with autoimmune disorders such as arthritis rheumatoid, Hashimoto, Sjogren? If yes, after how many years it could be helpful?
It is difficult to answer. It is very difficult, and I think it should be personalized, and we have to consider the specific patient and the specific disease, also disease activity, cardiovascular risk. So it is a choice not only related to the rheumatic disease, but we have to consider the specific patients. So considering the rheumatic disease, considering cardiovascular risk, considering the potential benefit, so probably the menopausal symptomatology. So it is difficult to provide a univocal answer.
Many thanks. Well, we have plenty of questions. We are already out of the time. One more question from Dr. Lisner. Does the recommendation about SLE and testing for thrombosis apply also for transdermal estrogens and non-synthetic progestins?
Frankly, I would. Frankly, I would screen. I mean, it's part of the workup for any lupus patient to check for antiphospholipid antibodies. So that plus the clinical history of recurrent miscarriages or thrombotic events, both arterial and venous, would be part of the workup. I would definitely do that.
So in this case, you have also answered. There is another question very similar here, and then Ellen Lisner again. One more, just the last one. Discussion of testosterone as part of hormonal therapy for menopausal women. It seems like as a hormone that starts declining earlier than estrogen and is known for calming rather than stimulating the immune system. It would be rather indicated. I don't know if it is a question or it is just a statement, because there is no question mark. Maybe we may go to the other, to take the next one as the last one. It's from Professor Indu QC from Nepal now in Africa. Is there a correlation between cough and arthritis in perimenopausal ladies? This is quite...
That's a question we get a lot. Generally, rheumatoid musculoskeletal pains do worse in cold months, okay? It's hard for an arthritis to be at its worst in August, at least at our latitudes. Nevertheless, if you ask why that is, nobody knows. Same for humidity in the environment. Everyone will claim there's an effect, but the mechanism for that is impossible to pinpoint. So yes, for the severity, especially when it's easy to spot, like Raynaud's phenomenon in the periphery, but also for pain in general, including inflammatory pain. So I'm sorry, but that's the best answer we can come up with. It's very close to common sense, I'm afraid. There's not much science there.
A very practical question. Okay, so it was a real pleasure to have both of you here, a real pleasure to have our audience. And now it's time to just close this session by including some slides. Just a second. Yeah. Okay. Here we have. Yes. This is just to show you the many advantages that one may get by being a member of International Menopause Society. And well, you have the possibility of joining the World Congress, interview series, climacteric, menopause info, webinars, clinical colloquium, and so on. Next slide, please. Yes, this is the advantages, the resources that you may have. It's the exclusive offers for IMS members, free 1-year IMS membership with completion of IMPART Level 1, IMS membership offers in partnership with local regional societies who are members of CAMS, and monthly live events and extensive library of educational resources. Next one, please. Yes, and not least, just remind that we have the World Congress of Menopause in September in Rio, so you are all invited. Many thanks again to both of the speakers and the audience, and I'll see you in the next webinar. So thank you.
Thank you.
Thanks, everybody.